Good evening, everyone. Welcome to Tuesday's webinar session from Yashoda Hospitals Critical Care Medicine Department, wherein basically we delve into the very good topics into the depths of these topics, and we explore the latest trends, insights, and different perspectives of our speakers and expert panelists in these sessions. So, which is most sought after. With this, I am very much pleased and privileged to welcome Dr. M. V. Rao sir. He is a senior consultant physician and renowned expert. I had read his articles across newspapers, especially about dengue and all. So he always educates the people about the regular topics, very much sought after. So I think the sir's experience and expertise definitely promises to provide valuable insights into this topic. So I welcome you, sir, on board.
Thank you, Kaladhar.
Yeah, to go through this topic, which is dengue scare, varied spectrum of presentations. So we are having the 4 speakers on this evening. So I welcome Dr. Shasidhar, who is a senior consultant critical care medicine at Yashoda Hospitals, Secunderabad, and Dr. Srikanth Akula, is consultant critical care at Yashoda Hospitals, Malakpet, and Dr. Goutham is a consultant critical care medicine at Yashoda Somajiguda, and Dr. Nithin is a consultant critical care medicine at Yashoda Hitec. So with this introduction, we will start the topic. Dr. Shasidhar, please.
Good evening, everyone. Good evening, Emirao sir.
Good evening.
I am going to talk about the liver presentation of the dengue, sir. Initially, we will take a case and then I will discuss about the literature. So, next slide. So, this is a recent case which is admitted to our ICU. Basically, a young boy, 20-year-old boy, presented with history of fever with rashes all over the body and body pains, vomitings for 4 to 5 days. Initially, he was admitted and evaluated outside, where the labs have shown thrombocytopenia with deranged LFT, coagulopathy, and raised renal parameters. In the same hospital, the dengue NS1 was positive, which I am going to show in the subsequent slides. In the hospital, while resuscitating the patient, he gradually developed breathing difficulty, restlessness. With those complaints, he was referred to Yashoda Secunderabad. On arrival to ER in Yashoda, he was tachypneic with a respiratory rate of 45, tachycardic with a heart rate of 120, and BP 160. And neurologically, he was looking okay, except for orientation to place and time. So because of tachypnea, he was connected to NIV in the ER and he was shifted to the ICU. Next. So these are the labs which were done in the outside hospital, which has shown a hemoglobin of 17.8, 17.2 with hematocrit of 48 and platelet count of 64 with the TLC of 6. Next, 6,000. Dengue NS1 was positive there. Next. And liver enzymes were not raised, but the bilirubin was high. Next. This is more of conjugated hyperbilirubinemia, and creatinine was 2.4. So considering all these investigations, the dengue was kept as a primary diagnosis. And next slide. He was started on judicious IV fluids after assessing IVC, and ceftriaxone and doxycycline was started along with the other supporting medication. And we have sent the labs again in our hospital. Next. So these are the labs in our hospital serially. Initially, his platelet count was 50,000 with a INR of 2.5, and his bilirubin is almost same. Outside hospital, it was same 6 bilirubin along with conjugated hyperbilirubinemia, and here also it is the same conjugated hyperbilirubinemia. But the enzymes were quite high. SGOT of almost 15,000, 14,650, and SGPT of 1,800. So looking at these values, again, we have a suspicion of co-infection with maybe leptospirosis and scrub typhus. So we have sent dengue, lepto, scrub, IgM this time. And because he was having concentrated urine and raised renal parameters, creatinine of 4.1 and CPK. CPK was also very high, 15,000. We continued the judicious fluids and doxycycline. Meanwhile, we got the dengue IgM report positive, both were negative. Looking at these values of transaminitis, started on NSTL 16, non-paracetamol dose, that is 100 mg per kg infusion, and he was continued on NIV. So because of low urine output and metabolic acidosis, we have done one session of dialysis. With that, he has shown improvement in the respiratory part. Next slide. So this is the ultrasound, which is showing polycytositis picture with the bilateral pleural effusion, more on right side than left, with edematous gallbladder and mild ascites. Next slide. So dengue IgM is strongly positive in our hospital. Next. So after dialysis, he was off NIV, and initially he was having grade 1 encephalopathy. To say it as acute liver failure, maybe that may not be fitting into the full criteria. He's having jaundice, coagulopathy, and grade 1 encephalopathy, which might be because of uremia and even hypoxia also. We can label him like dengue-induced severe hepatitis, at least, if not acute liver failure. So initially, we thought if LFTs were worsening, we wanted to go ahead with plasma exchange, but serially, LFTs have shown to improvement in the lab values, and his clinical condition also improved. Today, he is in session of dialysis. He is undergoing dialysis. After that, we wanted to shift him to the room. That was the case. Next slide. Next slide. Coming to the literature. Next slide. So liver involvement is quite common in dengue. Which is more seen in severe dengue than non-severe dengue, and the prevalence when we see it is more in adult population than in children, pediatric age group. The common symptoms of liver injury are abdominal pain, nausea, vomiting, and anorexia. These are the warning signs of dengue also. Persistent vomiting and abdominal pain are warning signs of dengue. And coming to the clinical examination, when clinical features, what we see are hepatomegaly. That is also, if it is palpable liver of more than 2 centimeters, is a warning sign. And in the labs, we will see typically transaminases. According to the studies, the incidence is varying almost from 50 to 97%. Next slide. So coming to the mechanism of liver injury, this is a combination of mechanisms. It is one entity is because of direct viral injury to the hepatocytes, and other two mechanisms which were thought are dysregulated immune response because of the dengue and hypoperfusion causing the ischemic liver injury, which is usually seen in case of the capillary leak syndrome. Mild hepatitis, usually that is maybe 2 to 3 times size of the liver enzymes, is commonly seen in dengue, which is because of the direct viral injury. While severe hepatitis or acute liver failure is mainly a combination of all the 3 entities, that is dysregulation of immune responses and ischemic injury to the liver cells also along with the viral injury. So typically, by definition, if the liver enzymes are elevated more than that is called dengue
Some problem with
audio. By it is having coagulopathy and encephalopathy. So is it clear, sir?
And now, can you repeat what you said last
Hello?
3 sentences? Can you repeat the last 3 sentences? Can you repeat the last 3 sentences?
Mild hepatitis is because of... Yes, sir. Mild hepatitis is because of the viral induced injury of the hepatocytes, sir. And usually mild hepatitis is manifested like 2 to 4 times elevation of the liver enzymes. And severe hepatitis, that is dengue-induced severe that is maybe more than 400 SGOT, more than 400 SGPT is called dengue-induced severe hepatitis. And liver failure, as per American Association of Hepatology definition, it is combination of encephalopathy, coagulopathy. Next. So usually that is, according to various papers and studies, the incidence is reaching up to 97%, which is commonly seen. And SGOT is the most commonly elevated enzyme in case of liver injury than SGPT. SGOT typical elevation is seen after day 4, day 5. And there is a correlation between the viremia, liver enzymes, and albumin also. So SGOT is more prominently elevated on day 4, and its levels will reach to more than 2 times of day 4 values on day 6. After day 7, gradually SGOT levels will come down, and the way they rise, they will fall also. So they are the more prominent, rise is more prominent, and in the same way, even fall is also more prominent in case of SGOT. And alkaline phosphates, GGT, they are not. GGT can be raised because of bilirubin.
There's some disconnection, Pawan.
Hello.
Yeah.
Am I audible?
Yes.
Yeah. Oh, okay. So the pattern of rise is SGOT will be the first enzyme to rise. Usually, typically, it will be seen on day 4, and we should not go by the value of day 4 value of SGOT. It will rise, the rise will continue up to day 6. On day 6, it will reach to the peak value, and then it will fall gradually. And the peak of SGOT value rise and the lowest serum albumin will correlate with the maximum fluid leakage, that is 24 hours before the maximum fluid leakage, the peak will come. And then viremia, the peak of viremia will be seen 24 hours before this fluid leakage. So those are the correlation between the viremia, fluid leakage, and the enzymes women. And coming to the immunological injury, there will be rise in the IL-10 level and IL-17 values. So, but none of the studies have shown to proven any benefit with the blockers of IL-10 and IL-17. Only animal models were there where while blocking IL-10 and IL-17 receptors, there is some degree of improvement in the liver injury. Next. So coming to the treatment options, actually initial phase of dengue is very crucial, where there will be rise in the hemo concentration because of the capillary leak. At that point of time, if we appropriately resuscitate the patient, we can prevent the liver injury. If there is a rise in hematocrit by 20%, which is typically given in the guidelines by WHO, that can lead to the hypoperfusion of the liver, and that can cause more liver injury. If we resuscitate initially, that will prevent the liver injury. And once the liver injury occurs, there are some treatment options have proven to have any specific role. But commonly used entities are like NSTL-16, that is 100 mg per kg non-paracetamol dose given over infusion. And there are studies with Mars molecular albumin reabsorbent system. And controversial, when there is immunology, steroids can be given. There are some cases and studies where high dose of steroids or low dose of steroids both were compared. But coming to the Cochrane data, there is no proven beneficial role. And high volume plasma exchange, where almost 12% of the plasma volume has to be removed in each session serially, that is also not shown to have proven any major benefit. But these are the treatment options which are available. Next. And coming to the prognosis, dengue-induced severe hepatitis mortality is very low. That is up to just 0.8%. But once it goes into the stage of liver failure, the mortality reaches up to 60%. So though acute liver failure is very rare in case of dengue, the mortality rates are quite significant. It is not only just because of the impairment of the liver function, but also because of the inflammatory response and multi-organ dysfunction. And predictors how we can decide the mortality rate is MELD score and INR level. MELD score is the best predictor when the patient is in dengue-induced severe hepatitis. If the MELD score is more than 15, then there is a high risk that patient of severe hepatitis may go into acute liver failure. So when you see that, you have to immediately intervene and prevent the next progression of the severe hepatitis into the liver failure. And INR is the single best predictor of the mortality once the patient develops acute liver failure. So this is the literature which we have and which is the consolidated data. Thank you.
We will proceed to the Next PPT presentation, Srikanth Akula. Dengue ARDS. Srikanth? Srikanth?
I'm able to hear you, sir?
Yes, yes.
Yeah.
Please
sorry.
proceed with your presentation.
Yeah. Good evening. I'm Dr. Srikanth. So I'm going to deal with ARDS. So this is my case scenario. He's a 32 years old male with a nil comorbidities. Presentation to our hospital with high-grade fever with myalgia since 8 days and severe shortness of breath, which usually was grade 2. And when he presented to the hospital, he was in the grade 3 to grade 4. And cough and multiple episodes of vomiting since 2 days. So he came with this presentation, and when he received to the hospital, and on evaluation, we found that the patient was febrile, his temperature is 101, tachycardic, and hypotensive. In spite of the fluid resuscitation, we started an vasopressor support and tachypneic. And it was a hypoxic, saturation was around 80%. So started an NRBM with 15 liters per minute. So on auscultation, there was a bilateral wheeze. Next slide. So initial investigations. So and the platelet count found out to be 95,000, and there was a mild AKI, and there was a rise in the HOD LGBT transaminitis. Dengue NS1 and IgM was sent as a part of the equifebrile illness, which came out to be positive. Next slide. Next slide. Yeah. So we received the patient. Sorry, previous slide. We received the patient ICU. When we received the patient in the ICU, patient was conscious, but he was hypoxic, requiring 15 liters of oxygen. But the patient is tachypneic, not in the distress at that point of time, and he was hypertensive after fluid resuscitation also. And we started a vasopressors, which is requiring 6 ml. So ABG was done and found out to be hypoxic. PO2 was 52 and 15 liters of oxygen. So the fluid resuscitation was continued, and then started HFNC with 60 liters of flow and FiO2 90%. As a part of the fever management, we sent the sepsis worker, and the PF ratio was less than 100. So in spite of the HFNC, patient was not improved in oxygenation. So we intubated the patient after coming to ICU after about 4 hours. Next page. Post-intubation, we connected the patient to the ventilator, volume control assistant. And when we ventilated, and the plateau pressure at that point was 28, and the saturation was 80. So peak titration was done. As the peak titration was increased from 10 to 12 to and 15, slowly saturation was improved. And but still is requiring FiO2 was 100%. So we planned the prone. So the proning was done around 3 p.m. So post-prone, the FiO2 requirement came down, but still the PF ratio was less than 100. But after fluid resuscitation and improving oxygenation, his hemodynamic has improved. Next. And the next day after 16 hours of the prone ventilation, we supined the patient at the 6 a.m. So there was slight improvement in the X-ray, patches has been resolved, and next, on supine position, the PF ratio has improved from 164. From less than 100, PF ratio has improved to 164 after first session of prone ventilation. So patient was given a interval of 8 hours, and again we done the second session for cone ventilation around 2 p.m. After the second session, we again did the AVG, and the PF ratios came down to 142. Next slide. And tone ventilation of second session, the PF ratio was improved to 324 from 160. So we supine the patient after 16 hours of tone ventilation. So post-pone, post-supination is a PF ratio was maintaining around 225. So we stopped the paralytic agent and we continued the sedation. And if you see the X-ray from the compared to first X-ray, the X-ray infiltrate has been improved. Next slide. Next slide. So, and the day 4, patient on supination, the PF ratio was improved to 320. So patient was weaned from the ventilator, and we extubated the successful to NIV. On NIV, his PF ratio was 252. So patient was maintaining with the face mask. So we gradually weaned from NIV to face mask, and then we shifted the patient out of the ICU. Before discharge, we did a CT. So CT shows a multifocal patchy areas and consolidation, bilateral GGOs, and the patient was discharged on the day 7. Yeah, next slide. So when you see in the dengue, dengue ARDS, isolated ARDS in the dengue patient, which is a rare manifestation when compared to other things. Usually dengue and the pulmonary involvement, most common presentation, what we see is a pleural effusion as a part of the polyserositis with the pleural efficiency and SIT. And usually this patient complains of dyspnea as when the patient is having a pleural effusion, massive pleural effusion, usually present dyspnea. So ARDS in this patient usually rare, but this patient as a part of the multi-organ dysfunction, dengue shock syndrome with multi-organ dysfunction, the most commonly this they have a ARDS. So mostly in the ARDS, the patient will have hypoxic with widened AA gradient and a non-cardiogenic pulmonary edema. And sometimes these patients also presented with a diffuse alveolar hemorrhage. But most of the times, the classical symptoms of hemoptysis may not present in this ARD in the dengue patient. Next. When you see the literature, this is an article from the Egyptian. So when they have seen the dengue patient, next. The ARDS is, and the typical dengue fever, the chances of getting ARDS is less, but when the patient is going into a dengue hemorrhagic fever and dengue shock syndrome, patients having ARDS chances are very high. Next slide. This is an article from India, North India. So they also present the same thing. Patient with a dengue hemorrhagic fever and dengue shock syndrome going into ARDS are very high. So chances in the dengue shock syndrome is almost 50% of the patients each eventually land up in the dengue ARDS. Next slide. Next slide. So when you see the pathogenesis, is a typically here is a inflammatory dengue usually causes the cytokine inflammation, which results in the inflammatory in the lung tissues, causing a hyperplasia of alveolar macrophages and the hypertrophy of type 2 pneumocytes. So results in the dilatation of lymphatic spaces in the subpleural spaces, results in alveolar congestion in the septal hemorrhages, and leading to acute diffuse axillary hemorrhage, usually seen in patients with severe dengue. Next slide. So as I said, usually in the dengue patient, when the virus infected the patient, the immune system usually responds and results in antibodies and inflammatory mediators. So sometimes what will happen, these inflammatory mediators have things like immunoenhancement. What means the patient will get the immunized when the different serotype of dengue again the patient will develop. So it results in the severe immune response, which results in the cytokine storm. And also, these patients have a increased vascular permeability. This is a hallmark features of a dengue patient where there is an integrity of blood vessels will lose because of the cytokines and inflammatory molecules. As a result of vascular permeability, there will be accumulation of fluid in the body compartments, also in the lungs. As the lungs get a congestion, there will be impairment in the gas exchange. When the gas exchange is impaired and also immune cells, inflammatory mediators causes the damage to the lung tissues. So both these results in the damage of the alveoli and results in the impairment of oxygenation and the carbon dioxide removal. And these patients leads in the hypoxemic and eventually land up in the ARDS. Yeah. Next slide. So when you see the management, so management of ARDS in a dengue is similar to the ARDS of any other etiology. So low tidal volume, optimal peak, and maintain the driving pressure less than 15, plateau less than 28 is a ventilator management along with the fluid resuscitation. Fluid resuscitation should be the important, as these patients will be fluid is, sorry, I'm able to. So tissue perfusion should be maintained with adequate fluid management. Yeah. Thank you. Next slide.
So we will proceed with the next topic. Dr. Nithin will present Dengue AKI.
Thank you, sir. Hello, can you hear me, sir?
Yeah, Nithin, you can proceed. We can hear you.
Thank you, sir, and good evening, everyone. Myself, Dr. Nithin. So the next spectrum which I'll be discussing is AKI in dengue. So we'll start with the case, and following with, we'll start with a review of literature. Next slide. So here we have a 41-year-old male patient hailing from Karnataka who presented to our ER department on 13th August 2023 with complaints of fever with chills along with myalgia since 4 days. So he took symptomatic treatment at home, but his symptoms persisted. Later, he went on to a local hospital with the above complaints, and he was treated there with antibiotics and antipyretics. Upon evaluation, it was found to have leukopenia with a WBC of around 2000 with a thrombocytopenia of 35,000. So based upon his CBP, dengue profile NS1-AG was sent, which came out to be positive and was treated according to it. Gradually, over a period of time, his thrombocytopenia worsened to 10,000, where he was transferred 1 SDP. Next slide. So on day 3 of hospital admission in the local hospital, he had a sudden onset of shortness of breath with a requirement of oxygen support. With worsened renal parameters, his creatinine jumped to 2.3 with a urea of 51, LFT derangement, and hypotension requiring NORAD support during the hospital stay. So during this point of time, he was referred to a center for the further treatment. Personal history, he was a diabetic on oral hypoglycemic agents and morbid obese and with good hypoglycemic with good control. Next slide. So upon arrival in the ER, the patient was afebrile, tachycardic. His BP was 100/60, requiring a NORAD support, double strength NORAD of 10 ml per hour. And he was tachypneic on 3 liters oxygen support with a saturation of around 93 to 94%. On examination of the lungs, we could see basal Krebs were present. Neurologically, he was intact, and per abdomen, it was normal. The Foley's was in C2 with a urine output for the first 2 hours was 25 ml. On ABG, arrival ABG, we could see there was high anionic gap metabolic acidosis with a pH of 7.28, a bicarb of 16.4. In the lactates was around 6.9. In the ABG, the creatinine was 3.3 with a base excess of minus 10.1. Next slide. So all the necessary lab investigation was sent in the ER, and a POCUS was done at 2D echo suggestive of good biventricular function with IVC of less than 50% collapsible. Then there was a B profile on the USG chest. So we started empirically on injection piperacillin tazobactam adjusted to the renal dose of 2.25 gram TID and injection doxycycline 100 milligram IV BD and other supportive therapy was started. And the patient was shifted to the ICU for the further treatment. So at the same time, we took a nephrology consultation in view of his metabolic acidosis, his oliguria, his shock and high lactates, and they advised for a CRRT. Next slide. So his baseline investigations on the day of admission were his total count was around 24,570 with a peripheral smear. There was no toxic granules seen. Platelet count was 20,000. INR was elevated with 1.6 and APTT of 76.8. His CRP was 77.5 and a procalcitonin was 110. On the renal parameters, the creatinine was 2.91 with a blood urea of 50. And the LFT wise, his total bilirubin was 2.82 with a conjugated bilirubin of 1.34. His OTPT were 450 and 154. On CUV examination, we could find only a protein of 2+, but there were no pulses and no suggestive of any urinary tract infection. So based upon his AKI, LFT and deranged LFT and thrombocytopenia, we sent dengue IgM, IgG along with a lepto and scrub IgM. Along with that, we have sent blood and urine cultures were sent. His ultrasound abdomen was done to look at the renal parenchyma, and we could see that there was a hepatosplenomegaly with a GBO edema, suggestive of a polycirrhosis picture with a normal renal parenchyma. Next slide. So this was the X-ray which was done on the day of admission. As you can see, the lung parenchyma looks clear with a slightly blunted CP angle with a mild perihilar congestion with a dialysis sheath in situ. Next slide. So during the ICU stay overall, we transfused one SDP because he had a oral bleed and gum bleeds were there. And his dengue IgM and IgG came out to be strong positive. Gradually, his oxygen requirement and the NORAD requirement stopped. We could wean him out from the oxygen support. And at room air, he is able to maintain saturation of around 93 to 94%. And hemodynamically, he was stable. His LFTs gradually improved over a period of time. He was in our ICU for a period of around 4 to 5 days. And his platelets also gradually improved from 20,000 to 1.3 lakh. And a ANA profile and complement levels were sent in view of his persistent AKI and oliguria, which were normal. And the AKI and the creatinine, which was on the time of discharge, were around 4.24 with a urea of 91.72, and it was still oligoanuric. And the total of 3 sessions of CRRT and 5 sessions of HDF was required for him. So overall, he improved clinically, and then from the nephrology perspective, he was advised for alternate day dialysis, and the patient got discharged on request due to some financial constraint. Next slide, please. So coming to the review of literature, next slide. So AKI, an abrupt decrease in the glomerular filtration rate, is one of the serious complications found in dengue. In the recent time, we could see there is a high incidence of AKI associated with the dengue virus infection. And as we could see, 6.7% patients presented with severe dengue, out of which 3.3 to 4.8% patients develop AKI, and of which 14.1% require dialysis. So this was in Sri Lanka and the other Asian countries. Next slide. So, and the need for dialysis can reach up to 70% in patients with dengue in the ICU care. So this is a picture, as I said before, the patient who presented with dengue, around 6 to 6.5% has a severe dengue, out of which 3.3 to 4.5% has AKI, and out of which 14.1% require dialysis support. Next slide. So this was an Indian study, which was a 1-year hospital-based prospective cross-sectional study. Next slide. So as you can see there, the patient presented with, this was done in around 160 patients. So out of which the patient presented 72% has a dengue fever without warning signs, and with warning signs were 13%, and with severe dengue was 14.2%. Whereas the patient who in severe dengue, the patient presented with AKI was 27.5%, and the other 72.5% patients were normal without any AKI. Next slide. So what they could hypothesize was every 1 out of 3 patients with dengue fever is likely to present with raised serum creatinine as a consequence of dengue, and accordingly are at high risk of developing AKI. So they postulated that this acute nephropathy can be related to prerenal ARF, consequent to third space loss of fluid. But the other spectrum, which was least studied, was from mild glomerulonephritis to urinary sedimentation to severe AKI. Next slide. So, and they concluded that there are some independent predictors like male gender, advanced age, hypotensive, high serum creatinine, blood urea levels at the time of admission, and low platelet counts on admission, evidence of polycystic and other complications. All these factors lead to AKI in case of severe dengue patients, and persons with dengue fever with warning signs and severe dengue has more evidence of AKI compared to patients with a dengue fever without warning signs. Next slide. So this was the literature which I could come upon. This was from the Malaysian group. Next slide. Here they looked at the incidence of dengue-associated kidney injury. In all these studies, the first one is the Indian study, another from the Pakistan, from the Sri Lanka, and from the Malaysian. All were retrospective studies, and all were done in almost like 200 to 500 patients. The definition what they used for AKI was the Akin study in most of the cases. Next slide. And next slide. And coming to the mechanism for the etiopathogenesis, we all know that the hemodynamic instability, which we usually see, which leads to increase in the inflammatory cytokines, leading to activation of complement levels, leading to endothelial injury, which causes a increased vascular permeability, leading to intravascular volume depletion, more of like a pre-renal, which results in shock and reduction of renal perfusion, leading to acute tubular injury. So most of the studies, what they have looked into was the higher frequency of hypotension and sepsis requiring inotropic support. In contrast, there are some literature and reports where AKI cases were there even without a hemodynamic instability. So the other causes which can lead to all those were, one is viral action on renal tissue, where the viral antigen per se will cause a cytopathic effect on the renal tubules due to some immunological mechanism, leading to a renal injury, leading to AKI. The second would be rhabdomyolysis, where the myotoxic cytokines, which cause a intense inflammatory reactions, leading to intense intrarenal vasoconstriction, renal tubular injury, and tubular obstruction. And some cases we could see there is an increase in raised CPK levels with AKI, and there are some reports where even with increased CPK levels, there was no AKI also. The other spectrum would be a glomerulonephritis due to some cytopathic changes with a high increase in proteinuria. And when the histopathology findings, we could see a reversible mesangial proliferation. And the other spectrum is hemolytic uremic syndrome with a triad of hemolytic uremia, thrombocytopenia, and AKI. Where in the renal biopsy, we could see thrombotic microangiopathies with microthrombi. And most of these patients survive with recovery of the renal function. So these are all the mechanisms what we could find. Next slide. So as I said before, this is a pictorial picture where independent predictors like a middle-aged, male, diabetic, hypotensive, obese, concomitant bacterial infection, and delay to hospital presentation, use of nephrotoxic drugs with the presentation of dengue. And with all these mechanisms of hemodynamic instability, direct virus injury, immune and autoimmune mechanisms of rhabdomyolysis, with a severe cytokine storm, with IL-6 high increase in the IL-10, IL-17, which all leads to a kidney injury, leading to AKI. Next slide. So this was all studies which we could compare, and where they looked into the mechanism of acute injury and dengue fever. So in all these studies, the proposed mechanism, what they could find was rhabdomyolysis leading to acute tubular necrosis in almost more than 50% of the cases. In some cases, they couldn't find any mechanism. And in some of them, they could find a deposition of immune complex and ATN, acute tubular necrosis. And all the patients were treated with renal fluid management, hemodialysis, and some patients require a renal biopsy to diagnose it. And the outcome was in more than almost 90%, they were all alive. In just 2 or 3 studies, they could see the outcome was they died. Next slide. So based upon all this, so how do we manage the dengue patient presented with AKI? So the main thing is the patient assessment in case of warning signs of severe dengue, together with blood volume assessment, are important starting points for the prevention of AKI. So the fluid administration should be optimized, especially with the crystalloids, with infusion rates and controlled tonicities to avoid osmolar disorders, fluid overload, and worsening of intravascular fluid extravasation. Next slide. And RRT may be necessary in some patients with AKI, especially as we've seen in our patient because of refractory uremia with hypercatabolism, metabolic acidosis, hyperkalemia, and hypervolemia. And if the patients are unstable, the modality would be to go for a continuous CRRT machine whenever it is available. And peritoneal dialysis is associated with the severe outcomes. Next slide. So to conclude, The prompt and careful medical evaluation of patients with severe dengue is very important, with maintenance of blood volume, avoiding the use of nephrotoxic drugs, with clinical and laboratory monitoring of early detection of AKI. Basically, we need to follow AKI prevention bundle to enable better management of the condition and avoid its complication. And emphasis should be on the need for post-discharge follow-up of individuals who developed AKI in dengue. Thank you.
Thank you, Dr. Nithin. Yeah, we'll proceed with the presentation of dengue encephalitis. Dr. Goutham, yeah, please proceed. Goutham, you are not audible. Dr. Goutham. Is there a problem? I think, yeah, if there is a problem, yeah, we'll proceed with the presentation. I will present the cases. So, dengue encephalitis, next slide. So basically, this patient came to our Yashoda with a 47-year-old female who came with the presented fever with chills since a week. So then it subsided 2 to 3 days ago. There was low backache, myalgias, and weakness. So there was history of hysterectomy in the past with the restless leg syndrome. The neurological examination upon coming is neck stiffness and upper limb tremors were there. So initially, anyway, we thought of possible encephalitis meningitis. Culture sensitivity were sent. Antibiotics were started. MRI brain was done, which was normal actually. So while taking in, she had thrown a seizure, generalized tonic-clonic convulsions, wherein we had given injection Levipil and then shifted to ICU. And there was post-ictal confusion in ICU. So the lab showed platelet count was normal, TLC normal, and there was transaminitis picture. So next slide, please. So she was having recurrent GCS. So in view of this status of epilepticus kind of thing where she was not regaining consciousness, we had to intubate her for airway protection, and anti-epileptic drugs were added and they were optimized. So EEG was showing epileptiform discharges. So neuro review was taken and then tropical workup was sent. So LP done, which was showing raised protein, which is 115 milligram per deciliter, and there were 400 cells. So which were 90% lymphocytes. ADA, HSV, PCR all are negative. So the dengue IgM came positive. So surprisingly, this patient actually after 3-4 days of intubation and the patient's sensorium got improved, there was no seizure activity. So we had given spontaneous breathing trial and extubated the patient. Then she was shifted to ward and discharged after a few days. So next slide, please. So the case 2 is a 21-year-old male. She presented with high-grade fever with chills, headache, vomiting for 4 to 5 days, and there were no comorbids as such. So she went initially to a local hospital where the complete blood picture showed thrombocytopenia. They did malaria, of course. The most common thing outside they do is viral, which was negative. So she was having hematemesis, melena, so all bleeding, gum bleeding. So she received outside SDP. Then she developed even oliguria and hypotension. Then she came in a bad shape to us. ER initially started with NIV. Anyway, she was worsening. So then intubated. ABG was showing severe acidosis, tropical workup and CT chest brain done. So noradrenaline was 10 to 15 ml per hour. So there was definitely acute liver injury. So with the enzymes elevated to thousands, SGPT of around 3,000, SGOT of more than 10,000, INR elevated. So she was, she even had VT with pulse, so settled with antiarrhythmics. Next slide, please. CT chest was showing bilateral ground glass opacities. Next day, dengue NS1 was sent. So CT brain was showing hypodensities in thalamus, cerebellum, occipital, almost diffuse areas of the brain. So we had and increased the ICP. So 3% saline was started. So she was even started cytosol considering very young and started with the RRT, and she was having hypoxia also. So after ICP measures were taken, she was prone. Once the ONSD was looked after and when it came down because of severe hypoxia. So the oxygenation got better, but stopped sedation since she was trying to follow commands. So she was restarted on sedation and ventilated because of ventilated asynchrony. Then there were hemodynamic fluctuations. Again, she was started on noradrenaline. So she developed anisocoria, which was surprising after initial improvement. So then we suspected IC bleed. So repeat CT brain was done, and then increased size of bilateral cerebellar infarct, definitely impending herniation leading to hydrocephalus and herniation. So emergency DECRA was done, EVD was placed in, but bilateral pupils were dilated and they were not reacting. Of course, it's like a futile outcome. So at this point of time, we counseled the attendants, they went LAMA in view of poor outcome. Next slide, please. So these were the CT brain images of this particular patient, which if you look at the occipital area, there are definitely hypodensities. So which were extensive, causing the severe ICP rise, leading to next slide, please. Yeah. Next slide. So basically, dengue encephalitis, according to definition of Neurology Asia and Soares et al. And Carrot et al., they defined, if you look at the criteria of Soares et al., presence of fever, acute signs of cerebral involvement, including altered consciousness and personality, and if there are seizures and with focal neurologic signs, and if it is a reactive IgM positive or NS1, or sometimes if you are able to do from CSF, there is no rise in intracranial tension, probably do CSF and send dengue PCR. If it comes positive, it points towards the diagnosis of possible dengue encephalitis. Of course, during viral epidemics, definitely there is a possibility of other differentials, something like Japanese encephalitis, where we have to rule out other viral encephalitis. And if you look at Carrot et al. Criteria, dengue diagnosis were highly suggestive for confirming acute dengue. Generally, the criteria includes CNS involvement, presence of dengue virus RNA or NS1 antigen in CSF. So we can both do dengue PCR and NS1 antigen also in CSF. So CSF pleocytis most of the times is lymphocytic involvement. So that points towards the possibility of dengue encephalitis. Next slide, please. The clinical features which are associated with the likely development of dengue encephalitis are, of course, the fever is most commonly seen. Next possible reduced consciousness, definitely if there is altered sensorium and drowsiness possible, this is the point which you should be thinking, and back of the mind thinking in the possibility of dengue virus encephalitis. And there will be headaches, seizures, generalized seizures is a possibility, as it was described in our case where she presented with generalized tonic-clonic seizures. Next slide, please. So the predictors are clinical generally, such as headache, high temperature, and if there is any hemorrhagic manifestations, and if the lab show low platelet count, elevated hematocrit, as we, I think, more and more discuss upon this, and deranged LFT with a background history of previous dengue, these are the recurrent secondary infection are prone towards developing this dengue encephalitis. These are the predictors. So next slide, please. So that diagnosis, as we were discussing in the criteria, during this monsoon season especially, you will be suspecting when any fever as a dengue. So clinical suspicion is there. And if there is any confirmation by lab, as we were discussing about NS1 antigen and dengue specific IgM, and if the CSF study, as I was particularly telling, if you do a CSF study, send dengue NS1 or IgM or PCR in the CSF also with abnormal brain imaging, as we were discussing about the involvement of cerebellar, bilateral thalami and all. So please, next slide, please. So these are the most common imaging findings. Most commonly, the thalamus, basal ganglia, temporal lobe and hippocampus, cerebellar regions, and the cerebral white matter. These are the most commonly involved regions of the brain when dengue encephalitis is affected. As such, even Japanese encephalitis also sometimes looks like the same kind of features, T2 hyperintensities in all these regions. Next slide, please. So the management definitely, more and more what we talk is hydration. So other GCS, airway breathing, circulation control, and if it is high fever, all the measures of neuroprotection have to be taken, like fever control, intensive monitoring. There are very low platelets and all. We have to give platelets and at the same time fluid replacement. So anti-ICP measures, as I was telling, and of course, if there is any IC bleed development, DECRA and coagulopathy correction. Some cases in dengue encephalitis, there are some case report where IVIG has been tried as a rescue therapy, but as such, there is no robust evidence towards this. Next slide, please. So the outcomes, most of the times, the patients recover without any focal neurologic deficits if they have not developed any increased ICP and without much of hypodensities, as we were seen in the first case where MRI was normal as compared to the second case, and some developed weakness, spasticity, post-encephalitic myelopathy, and there might be possible haptic neuritis. Most of the deaths will subsequently, they'll end up in multi-organ dysfunction, and rather than due to encephalitis, they may die with other organ dysfunctions. So, and there may be possibility of herniation. So some patients, they very fast, they progress and they lead to acute necrotizing encephalitis also, which will pose a very poor outcome in this subset of patients. So these are the different studies where they described the Kanki, Mantra et al. All patients recovered, and mean hospital stay definitely increases when they develop dengue encephalitis and all. Next slide, please. So these are the references. Anyway, thank you. So with this, I think we'll go to the discussion session. Enviro, sir?
Hello, Kaladhar. Yeah.
Yes, sir. So basically, we have discussed dengue, ALF, ARDS, yes, sir, AKI, and encephalitis cases. Yes. So with this background, just one, there is a term called expanded dengue syndrome. Generally, what we discussed, sir, where the patients will land up in multi-organ failure. I think you have a vast experience, so everybody knows it. So can you please tell us which type of patients generally progress towards? Most of the times, any patient gets admitted. The most clinicians, what they think is which type of patients may progress, which are the factors that we can look at and tell that these type of patients may progress towards the multi-organ failure.
Yeah, thank you, Kaladhar, and good evening all. And it's very interesting actually. It's a properly exactly during season of taking this topic, and I congratulate the critical unit of all the hospitals. The nice case presentations, and as you all know, of course, dengue typically has acute febrile phase and afebrile phase and recovery phase. Patient comes with 3 to 5 days fever, then afebrile may have the thrombocytopenia, hemoconcentration. Some of them have some other complications and they recover and go home. And some patients, in particular India, they say Indian subcontinent has so-called expanded dengue syndrome, where in acute phase, most of the patients who have only malaise and fevers, nothing to worry the patient vitals. But in some patients, they have so-called isolated organ involvement, like acute hepatitis, acute pancreatitis, AKI, encephalitis, or myocarditis like this. So there you have normal parameters, but you have isolated organ involvement. Like in the liver, the transaminases may be more than a few thousands. Patient may sometimes go into acute liver failure. And acute encephalitis, as you've seen other patients, so within a day or two, they convulsive state, they become unconscious sometimes, and we find sometimes changes on the MRI brain. Similarly, acute pancreatitis, all organs isolated get involved. So these patients who look the PCV, so-called hematocrit may be normal, they may have mild leukopenia, and the platelet count may be normal with normal PCV, as I told you. So it is not very uncommon in Indian subcontinent to see these patients. And during monsoon season, as you rightly told, you must always suspect about dengue etiology in these patients. In fact, the patient what you told last, the female patient with encephalitis, we thought it could be some other virus. When we did CSF, we thought it could be autoimmune encephalitis, and we gave steroid. In fact, Europe gave steroid before the result of the NS1 antigen came, or IgM test came positive. Then we continued steroids because there was dramatic improvement. So those steroids were controversial in dengue encephalitis. Probably it has some role. Similarly, coming to our patients, the first patient what doctor, who's that? The first case. Let me go to. Yeah, the first case, I think someone wrote about the some patient came to us with AKI after transfusion of the SDP. I think that case probably is not AKI directly related to the dengue viral infection. It could be sepsis. One important thing is that most of the patients who receive SDP outside, which is usually not required. In district levels, sometimes they give platelet transfusion when the count is more than 40 or 50,000 also. And most of the districts have blood bank somewhere. They transport the SDP unit to the hospital, small hospital, and they transfuse. This time, definitely the SDP gets contaminated. Even in the best hospitals, SDP contamination is not very uncommon. So most of the patients who come to district SDP transfusion come with severe sepsis, where the counts be more than 30,000 TLCs. This patient about 25,000, and this patient has procal more than 100. And all the features go in favor of severe sepsis. I think in that patient, the AKI was related to the so-called MOD or secondary severe sepsis. So my suggestion or my request is that avoid platelet transfusion, particularly in the districts where there are no facilities. Nowadays, latest guidelines say that you don't have transfusion even if the platelet count is less than 10,000. I have a patient where the count is less than 9,000, but I did transfuse. She improved within 36 hours. So don't worry about platelet transfusion. Only look at the hemoconcentration, so-called hemoconcentration hypotension. And another patient that I mentioned about this, why was the doxycycline given this patient of AKI, hepatitis? The one patient, they wrote that they gave doxycycline in hepatitis. Do you really suggest that? And second thing is the patient what you mentioned about hepatitis, the enzymes recovered within 24 hours. So that probably was looking like ischemic hepatitis. So I think most of the dengue patients in our country have ischemic hepatitis. So they usually have very good prognosis. So when you have a 10 or 20, 30,000 SEPT, SEOD, you don't have to really worry. So they do recover. Though there is a controversy about NAC infusions, we do give, but most of the patients recover once you give good amount of fluids. And did you check ammonia in that patient? I think West present case, I think the doctor has presented acute hepatitis.
Yes, sir. Ammonia we have not checked, sir, because he was in grade 1 encephalopathy only. And his enzymes 50% reduced on second day after giving an acetylcysteine. Doxycycline we have started with suspicion of co-infection with Leptospira or scrub. So that is the reason we
I think we have gone for the alternate drug like azithromycin or something like that. I think the oxy, because when the change is so high. And second thing is NAC is, of course, I think he or she responded to, I think, fluid resuscitation, not proper NAC. Of course, NAC gets the credit always. I think that is because of proper fluid resuscitation. And coming to this so-called ARDS, the one who presented, I think Dr. Srikanth presented that case.
Yes.
So how do you say that it's not because of fluid overload?
Sir, the patient came directly from the ER. After initial resuscitation, the first 24 hours fluid balance was only 2 liters. So,
but what was the fluid balance before coming to hospital? Did you have any baseline PCV?
No, he came directly from the index hospital. Directly he came to the hospital, sir.
Or not, he was not anywhere else.
Not different from anywhere.
Yeah,
but if you see that the PCV more than 40% change in a day or two.
Yes, sir.
Yes, sir. This patient.
The way he responded within 40 hours, the way he responded in 40 hours looks like something not like a direct injury to the lung by dengue virus. It looks like either a fluid leakage or something else.
Actually, we had this discussion. So, the thing is the possibility of that much rapid improvement, we even discussed that the possibility of fluid overload might not be ruled out. But one thing is we did not try any We did not give any Lasix in this patient. But of course, he presented with 8 days of history. As you said, it's a possibility because it might be in recovery phase where the fluid reabsorption might have happened and led to pulmonary edema.
The response was too good, actually, too rapid and too good. It disappeared.
Yes, sir.
So I was just thinking.
Maybe
combination
of.
Yeah. Maybe combination. Did you, in any of these, did you check for the serum ferritin levels?
No, sir. We didn't check actually.
Okay.
Actually,
But
because
I think now we plan, I think all 4 hospitals now together will start probably and probably checking serum ferritin levels and to see the severity of disease linked to the levels of ferritin or not. So I think we will probably formulate this thing and go ahead with the investigations.
Sure, sir.
And
Like
what about antibiotics? Are you giving antibiotic routinely to all these patients?
No, sir. Actually, when the patient came to the hospital, is a fever spikes and after initial fluid resuscitation also, his BP was very low. Before he just sent the sepsis workup as a part of the routine fever evaluation and started the steroids, antibiotics, in the ER. So once we got the results, everything, and then we de-escalated the antibiotics.
Actually,
did you
this
see
patient was being treated outside for 3-4 days, sir. Day 8 he presented. So we thought, is it a possibility of secondary bacterial infection? What do you think, sir? Secondary bacterial infection in dengue after 1 week or something?
Very, very uncommon. Surprisingly, I have never seen. Actually, I think I'd never give antibiotics unless, as I told you, there is a STP transmission fluid contamination where you have very high TLC count and high procal. In such case, we go for higher antibiotics. Otherwise, I never give prophylactic antibiotics which have no role. And any newer advances in the treatment of dengue? Can anyone update on this?
As Dr. Shashi was telling, especially in the context of dengue ALF, what is the role of high volume plasma exchange? We have done 1 or 2 cases in my past experience where the patients were worsening high volume plasma exchange and role of FFP replacement because the possibility RMTS 13 activity goes down, because of which there will be multimers of platelets and causing microthrombi formation. So which will lead to organ dysfunctions, where plasma exchange causes these multimers to be removed from the circulation, improving the organ dysfunctions. Shashi, any idea, any insights from you?
Actually, literature is there, but not much of any proven benefit.
Exactly.
And in CMC, from CMC, they have done in acute liver failure, acute and chronic liver failure, but not specifically on dengue patients. That is one area. And dengue, there is case reports from Thailand and other Southeast Asian countries where the data is very limited. One study, 5 cases, they have done high volume plasma exchange. In that, only 2 survived. 3 succumbed to that illness in spite of high volume plasma exchange. So role is little controversial, but we have only one modality available, so we are using it. In our hospital, in this session also, we have done 5-6 high volume plasma exchanges. 50% of patients survive.
In fact, in our most of our experience, all these atypical presentations, let it be acute hepatitis, or AKI, or pancreatitis, encephalitis, the progress is very good. The only way patients we lose is that sepsis, secondary to the transfusion of contaminated STPs. There we almost lose the patients because this will be very florid, because directly you are giving the bacteria intravenously, and sepsis will be very florid and they die within 3 or 4 days with multi-organ dysfunction syndrome. Otherwise, most of the patients, we had a patient with pancreatitis, with thrombosis, splenic infarcts, they recovered. We have a patient with encephalitis a decade ago where the dengue PC, the RNA PCR was positive in CSF. And he also had multiple other organ damage, but he still recovered. His name is Muttinjay Rao. Name is aptly. So he's from Padpali. I still remember he still comes to follow up. So he recovered. So like that, many patients with real, so-called expanding dengue, they do recover. The only problem, as I told you, is sepsis, they die. And second thing is that there is a lot of research going on the so-called NS1, non-specific one protein, because that is the one which causes the damaged endothelium and causes the endothelial dysfunction, so-called vascular permeability was worsened, and plasma leak will be there. Now there's a lot of this going on abroad, like North America, where they are finding some antibodies which are produced by human, also mice, so-called 2B7. These antibodies, they are now experimenting whether that can prevent the so-called dengue syndrome, so-called vascular permeability or destruction of other things. So now they are trying to do, they are trying to manufacture the monoclonal antibodies, and they're trying in the mice. The results are very good. In future, definitely we are going to have some cocktail-like thing. So there are a lot of this is going on. So if you get monoclonal antibodies against 2B7, so-called 2B7, this name as 2B7, against the NS1 antigens, I think this is going to change the treatment of dengue, because that will stop the so-called vascular fluid leakage and other organ dysfunctions, I think. Because even expanding dengue syndrome, NS1 is the culprit for damaging the either lung membrane or the hepatocytes or any other organ. I think, and another good thing is that this NS1 also seen in the other viruses, other flaviviruses like West Nile virus and Zika virus also. So they found a cross-reactivity. And once they come out with these monoclonal antibodies, I think the treatment of those is also become simple. So let us hope that this is going to come future. But I think if this comes, I think that's going to change the treatment tremendously.
Yes, sir. Regarding dengue ARDS, I think we had seen one patient is a 19-year-old pilot training undergoing. He presented with
yes, yeah, the Fugli.
Yes, sir. Oh, sir. Yes, sir. Yeah. So it was
that he was an ECMO. That was a fantastic patient. Actually, we have had all the complications in him, and we have seen all the dengue complications. Oh my God, that was phenomenal recovery. He's still coming for the follow-up, and fantastic case. I still remember all of you worked so hard for so many days. He was ECMO and he recovered. Dengue ARDS, everything. He had dengue hepatitis, he had pancreatitis, he had myocarditis. Oh, he recovered. Yeah, obese. Another important thing is that any patient who is obese, they are going to have more problems. Dengue is one infection where it's seen in immune competent people. You never see dengue, serious dengue or severe dengue in poor patients, malnourished people. It is seen in children who are obese, adults who are very obese. In fact, all the patients who are HLH, in fact, today, this time we had 2 or 3 patients HLH with dengue, all of them are obese. Maybe because of the large surface area, large peritoneal area, large pleural area, probably they have more plasma leakage, and maybe the so-called immunological reaction more common thing in immune competent patients. So any patient who is rich, who is obese, please be careful. They are going to have more problems.
Yes, sir. Yes, sir. So, what about your insights about this secondary HLH, sir, in dengue? Sometimes I think we had seen some patients where
yes, serum ferritin is raised in most of dengue patients. In fact, I'm doing it now. Most of the patients is raised; they are not becoming serious. So, 2 patients whom we treated for HLH, they recovered actually. 2 young patients who are HLH, they recovered. 1 patient we lost last year. In fact, that patient's sister came and again got admitted. They are so scared. So now she's recovering. She didn't have HLH, but she had hypoxia because she's very obese, but she's recovering. She had severe thrombocytopenia, but she's recovering. So dengue LH is not very uncommon, but recovery is good. In fact, Mishra must be knowing last time, this year we had 2 patients who recovered with the so-called steroids and hepatocyte.
Yes, yes, sir. Yes, sir. Regarding dengue encephalitis, sir, what do you think, sir? What are the patients that are at risk and how we have to go?
Dengue encephalitis is not uncommon. In fact, we see at least 3 or 4 patients a year, and all of them recover. So yes, whenever a patient with dengue, in fact, we had one lady last time postpartum, 7 days of postpartum, she developed severe dengue encephalitis, and she had continuous seizures. But I think she was, in fact, so many attendants came, and it was a scary situation. But she did very well, actually. She was on a ventilator for more than a week. She had multiple anticonvulsants and antibiotic drugs, and she made a good recovery. In fact, she had abnormal MRI scan. Despite all these things, she recovered. Initially, she had some deficits, neurological deficits, but she made out completely. Now she's perfectly normal, about 25-year-old female. So she was doing very well. So similarly, we had a few more patients of dengue encephalitis. All of them recovered. So somehow, dengue encephalitis looks scary in the beginning, but the progress is very good.
Yes, sir.
We have some questions in the question.
Yeah, there are some questions in the chat box. Yeah, one Prasanjit asked a question. What is the fluid choice in dengue during initial resuscitation? What targets we should meet and how to titrate it accordingly?
Of course, can anyone answer the question? Yeah.
Crystallites are preferred, sir. Crystallites compared to colloids, crystallites are preferred. And among that, NS is the choice in the initial phase until the patient develops hypernatremia or hyperchloremia. till that point of time, NS is the preferred agent. And when patient comes in based on the PCV, we have to adjust the fluids. Initial first hour, you can start with the 10 ml per kg and then gradually come down 7 ml per kg for next 2 to 3 hours. Later 5 ml per kg for 2 to 3 hours. Then we will continue with the 2 to 3 ml per kg dose. So that has to be continued. And HBPCV, ideally we have to monitor at least 6 hours so that what is happening with the hematocrit that we have to observe. And if at any point of time, if hematocrit is going high, that indicates a bad resuscitation marker. So if hematocrit goes high, there will be high possibility of liver injury and even kidney injury also because of the hypoperfusion causing to the organs.
One small tip here is that every patient who comes to you from outside hospital, please collect the report, CBP report of the day one. So that is a baseline. So that guide you, because that is very, very important. PCV is a very important indicator or guiding factor for the fluid resuscitation. So initially, sometimes if the hemoglobin is maybe more than 10, 15%, 20%, we give 20 ml per kg body weight. And as you said, then 10 ml, 5 ml, 3 ml, like that, it come down. But sometimes in the wards, roughly, for those, sometimes we cannot follow strictly guidelines. We simply say that it's about 100 to 75 ml hour, though not correct. But sometimes when we have less staff, particularly during monsoon season, we tell them to give some fluid continuously and check PCV 6 hours. Okay, as you rightly said.
There is another question, sir. Dengue CVRT markers, what we have to monitor in dengue patients in ICU?
Again, the most important thing is PCV and the fluid status. Of course, you know, focus, you can see the IVC. And the most important thing is, of course, look at the PCV, and PCV, not the platelets. So look at the PCV, and of course, so we totally go for the PT, APDT. There is a relation between the APDT and the prognosis of disease. In some paper, they say that prolonged APT more than 3 times have bad prognosis. Similarly, of course, if the patient has multiple organ damage or patient sepsis, their prognosis is very bad. But to the even ICU, the most important prognostic, or rather, guiding parameter for the treatment of dengue or fluid status is PCV only.
Yes, sir.
What about bradycardia you find, Shashi, in these patients while recovering? What is the lowest heart rate you have seen?
I have seen in 40s, sir, not less than 40. Bradycardia is quite common, which we see, but never that caused alarm to me.
Yes, I have seen a patient 39. In fact, I have taken picture also, but no, we didn't do anything except what is the role of calcium supplements these patients? Do you give calcium routinely for dengue patients or not? If so, why? Check. Anyone?
No, sir. Usually we are not giving.
Of course, I don't WHO guidelines. They say that you must use calcium supplement. They have not mentioned why. And I'm trying to read, but nowhere I could get the answer. One second thing, in our country, most of the patients have B12 deficiency. So that can retard the recovery of the platelet production. So all the patients should have a routine supplements with folic acid and also the B12, because the demands of folic acid and B12 may increase because of rapid pulse of platelets and the bone marrow. So better to give B12 and folic acid to these patients apart from the calcium.
There is another question, sir.
Yeah, please carry on.
Is there any role of prophylactic steroid in before encephalitis sets in?
No. In fact, there is a controversy whether to give steroids or not. So in our patient, as index patient, what I told you, just got discharged 2 days ago, the steroids were given in the patients suspecting autoimmune encephalitis. So some patient recovered within 24 to 40 hours, we continued. But literature shows that the role of steroids is still controversial. That depends upon the treating doctor. So there is definitely no role of steroids either in the treatment of dengue or the prevention of any complication, not only dengue encephalitis. Please don't use steroids because sometimes that can worsen GA hemorrhage. So don't use steroids in these patients.
Yeah, another question, sir. Status of vaccines for dengue.
Yeah, it's a very English problem. As you know that there is a problem of antibody enhanced the worsening of things. So we cannot give in naive patients. So any vaccine, dengue vaccine should be given in patients above 15 years of age, below 49 years of age, the two who are having antibodies already. So unless you are exposed to dengue virus once, at least once, you cannot take vaccine. And a lot of research is going on, but there is a problem in other country. I think Thailand, about 85 students died because of dengue AKI. So there are problems. It's very difficult to accept. Now trials are going in India also now. Let's hope that there won't be any problem in taking vaccine. Somehow it's not a successful vaccine. They are trying to push it, but I don't think it's really going to help.
Sir,
Another question is role of, yeah. Okay.
So
Nithin,
there was
yeah.
a middle-aged lady who presented with dengue encephalitis positive thrombocytopenia, AKI, LFT derangement, and everything, who got intubated. As Sir said, due to a plasma leakage, her oxygenation was low. It slowly got improved over a period of 2 to 3 days. Other parameters also improved. But when we were trying to wean her off the ventilator, we could see that she was not able to wean off. So we got MRI scan done where we could find hemorrhagic infarcts, which gradually improved with the dose of pulsing steroids for 3 days. Slowly her power also improved, sensor also improved, and slowly we could wean off from the ventilator. So do we see any
Infarcts where you are talking MRI?
from the cerebral parenchyma, sir?
Yeah. See, we cannot definitely say that steroids have no role. In fact, our patient, as I just put, she improved. So probably we have to reserve steroids only for the encephalitis or CNS complications of the dengue infection, not for other things like hepatitis, AKI, and other thing. I don't think they have any ARDS. I don't think steroids have any role. But definitely, like any other encephalitis, while encephalitis or ADEM, we do give steroids. So probably helps in CNS dengue. Steroids probably help in CNS dengue. Unless there is a contraindication, I think we should probably try steroids at the moment. Let's wait for the guidelines here.
Yes, sir. Another question is the role of doxycycline in dengue.
Yeah, there are some papers where the doxy say that they act as anti-inflammatory, not as antibacterial. There is no antiviral property, but they say dengue basically the inflammatory problem. So they say that it could probably decrease inflammation. In some studies that they could help bringing out the severe disease, but we are not giving out anything. WHO doesn't support that. Yeah.
There are questions, 2-3 questions about FFP transfusions role in dengue, sir.
Yeah, FFP is not indicated at all in these patients unless patients are bleeding with prolonged APTT. So prolonged APTT itself is not an indication for FFP transfusion. The patient has a prolonged APTT, started bleeding, despite having normal platelet count, or the platelet count is more, see, the platelet count is more than 20,000, patient is bleeding, that means there is some problem with the coagulation. So check for APTT and fibrinogen levels. If APTT is prolonged with normal fibrinogen levels, give FFP 10 ml per kg body weight. The patient has low fibrinogen levels, then go for the cryoprecipitate.
Yes. Okay. So is another question, sir, is dengue shock syndrome more aggressive in young adults than older patients in your experience?
Yeah, it is aggressive, though we don't see pediatric patients. Dengue shock syndrome is worse in pediatric population with a large surface area. It's also probably bad in patients who are obese in young adults. It is also bad in patients who are having comorbid conditions like cardiac and other issues. But in normal healthy alert, I think if you are really very good to follow, if we follow them very strictly, I think they do recover very well. In fact, treating the dengue shock syndrome is very satisfactory. They check their PCV every 6 hours and give judicious use of crystalloids. They do very well within 48 hours. No one dies in the hospital. The mortality of dengue shock syndrome is very, very less than, say, 0.1% in most of the cities in the world. Same with our hospital. No one dies of dengue shock syndrome. Most of the patients, what we lose because of sepsis or MODS, are patients who are managed probably not well outside the hospital. Before coming, they have problems. Yeah.
So another interesting question, sir, that's what we get from the attendance. What is the role of papaya, any fruit role for improvement of platelets in dengue?
Actually, WhatsApp really is doing a lot of damage to the general population. I have a patient with a bank employee, officer in the bank, got admitted with dengue infection and having persistent diarrhea. It's not coming down. And we thought it's infected diarrhea. Of course, dengue has diarrhea, about 10% people present with diarrhea. But this patient was having pain abdomen and going to do every 30 minutes, 1 hour, and not responding. Then we were giving fluids, was not responding. Then I asked him on day 5, what do you take? He said he took a lot of papaya leaves, boiled them, and took the juice And he also took the raw juice, he took papaya, he took kiwi, he took goat milk, all those things before coming to hospital. It took almost 12 days for him to recover from that. And when we did colonoscopy, there was a bad colitis, hemorrhagic colitis. So papaya is a dangerous, it contains papain engine. Sometimes they can cause GA bleed. And it's really bad. I don't think it's the benefits are very, very minimal. And we are not bothered with platelets. We are bothered with hemoconcentration. I think I hate papaya and I never give caripil or anything. There's a commercial, aggressive commercial promotion by these companies. So don't believe that this caripil is or papaya is going to help, because whatever caripil, the study says that it may increase the platelet count marginally. But that's not what we're looking at. We're looking at the hemoconcentration, fluid leakage. So that's not going to help. So don't give that. And same thing, kiwi fruit. So we had one patient who had reaction with kiwi fruit. They had anaphylaxis. So kiwi fruit known to have caused anaphylaxis. So try to avoid kiwi fruits, tell the patients. And we had one patient who had hyperkalemia because they were continuously giving food juice and also almost there was food shop in the room. So we food juices, coconut water, and he had hyperkalemia and had abnormal ECG changes. So whenever I go to a patient with the dengue room, the patient's room, first I told them to remove all the foods and food juices, ask them not to give anything. Already we are giving crystalloids and we never have hypokalemia. So don't give fruits and food juices. Don't give kiwi fruit, don't give caripil, don't give goat's milk. In fact, we wrote a few articles in press also. So that's going to spoil the health of the patients. And that gives a false security to the patients, feeling of security. So better to avoid all of them. Yeah.
Yes, sir. Yes, sir, I think we had answered almost the questions. So with this, I think we come to the conclusion of our webinar, sir. So any final comments from you, sir? Any key points want to?
Yeah, coming to the actually summary, dengue is a commonest viral infection during monsoon. And its disease spectrum is asymptomatic infection to the MODS. And most of the patients, they come in time, the diagnosis early, and proper care of trained medical personnel, the mortality is very, very low, less than malaria. And don't ever bother with platelet count. Tell attendance patients that platelet count is not important. What is important is the hypotension, hemoconcentration during the febrile period. Patients come in anxiety when NS1 is positive, when there is high-grade fever. But they want to go, they try to go home the moment they become febrile. So that becomes very tough for us to convince them that they should stay in the hospital. So I don't admit patients during febrile period. Tell them to go home and come back when they become febrile. So guide them properly, tell them about the disease process, convince them for that admission. And never transfuse platelets on the demand of the patient attendants. We had one ex-minister whose daughter admitted me in the Nizam Institute. He was crying when the platelet was 19,000. He requested us to give platelets. I told Dr. Razu, Nizam Institute, not to give. We never budged to that. We never gave. So don't give platelets unnecessarily because it's its own complications. One is immunogenicity. Second is possible of sepsis even in the best of the best blood banks. So avoid platelet time unnecessarily. Avoid blood component transfusion unnecessarily. No antibiotics. And of course, always communication with the patient attendants. Tell them that the mortality is low, but it can happen sometimes. So give fluids and don't give blood components unnecessarily. And tell everything to the patient every day. No? So that's all.
Yes. Thank you very much, Amira sir, for sharing this valuable experience. It comes from your expertise, very vast expertise we have seen. So thank you very much, sir, for coming onto this platform, sharing your views. And I thank our speakers, Dr. Shasidhar, Dr. Nithin, Dr. Srikanth Akula, and Dr. Goutham for bringing those very important and day-to-day good cases for this conversation to go on. So I thank all the viewers who almost around 130 people logged in. I think more and more people, thousands it will go, the viewers will be seeing. So I think I thank Yashoda Hospitals for giving this opportunity on this platform. So thank you, everyone. Good night and take care. Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you, sir. Good night, sir.
Good night. Good night.